Hello everyone. So in this video, I'll be talking about prevention strategies for PD-associated peritonitis. So this is the overview of my talk. We will first talk about why prevention of PD peritonitis is important, the epidemiology and impact of PD peritonitis, the key risk factors associated with it, core prevention strategies, and some adjunctive measures to prevent PD peritonitis. Let's first understand the statistics. As of 2025, approximately 4.9 million people across the globe are on dialysis. Only about 11% of them are on peritoneal dialysis. So approximately 540,000 patients across the world are on peritoneal dialysis as of 2025. In India alone, 8,500 patients are on peritoneal dialysis. If we look at the rate of peritonitis, worldwide there are reports ranging from 0.2 to zero point 0.6 episodes per patient year, while in India there are reports ranging from 0.46 to 0.55 episodes per patient year. There's also one study from North India which gives a report a peritonitis rate of 0.7 episodes per patient year, while the ISPD has a target of less than or equal to 0.4 episodes per patient year. Now, why is prevention of PD peritonitis important? Because it increases the rates of hospitalization by 30%. It leads to catheter removal in 30 to 50% of the patients, and 5 to 10% of the cases are associated with mortality. This is exactly why we have to work on prevention of PD peritonitis. If you look at the global impact of peritonitis, 16 to 20% of the cases lead to technique failure. Peritonitis is a primary driver of PD technique failure. In the United States alone, annually 20,000 cases occur, and it is a huge economic burden, not just for the patient's family, but also for the healthcare system of the country. It doubles the healthcare costs. Now, if you look at the trend of incidence of PD peritonitis over the last few years, you can see that the trend is decreasing. This is mainly because of the improved dialysis techniques and comprehensive patient training programs. The common causative organisms are gram-positive bacteria in 40 to 50% of the cases, primarily coagulase negative staphylococci and Staph aureus, often linked to skin flora contamination. 15 to 20% of infections are because of gram-negative bacteria, that is E. coli and Pseudomonas, frequently originating from the enteric sources. Fungi in 5 to 10% of the episodes, mainly Candida species. These are often difficult to treat and are associated with worse outcomes. And 10 to 20% are culture negative. No causative organism is identified, posing diagnostic and therapeutic challenges for the patient and the clinician. Now, coming to the risk factors for PD peritonitis, we can categorize or classify risk factors as patient-related, technique-related, and environment-related risk factors. We will see each of it one by one. Now, coming to patient-related risk factors, diabetes mellitus increases the risk of infection by 1.5 times. Many studies have already proven that hypoalbuminemia is directly associated with increase in risk of infection. So malnutrition is directly affects the immune system and is a risk factor for PD peritonitis. Reduced dexterity and vision. This directly leads to breach in the technique of performing PD exchanges, leading to increasing the risk of infection. Comorbidities such as SLE or lupus nephritis directly affects the immune system of the patient, again predisposing the patient for infections. Nasal Staph aureus carriage increases the risk of infection by 2 times. Coming to technique-related risk factors, manual versus automated peritoneal dialysis. Manual exchanges carries 1.2 times higher risk because of increased handling. Connection methods. Earlier, spiking systems were used, but presently, because of increase in risk of infection, we have now switched to Y system. Poor aseptic technique. Inadequate catheter care, including poor exit site care and catheter hygiene. Frequent disconnections, more connections means more opportunities for infection. So here is one study looking at the initial peritoneal dialysis modality and the risk of peritonitis. This was a multi-center study conducted in Japan over a period of 4 years. So they compared 106 automated PD patients versus 106 CAPD patients, and they found that the peritonitis rates were reduced in APD patients compared to CAPD patients. This is mainly because of fewer manual connections and shorter dwell times with APD, which likely reduce the touch contamination and hence the peritonitis rate. Coming to environmental risk factors, unclean living environment can introduce harmful bacteria. Contaminated water sources poses a significant infection risk. Pet ownership. Maintaining sterile techniques when someone is traveling is very difficult and requires careful planning. Now coming to the core aspects of prevention, structured patient education and retraining, aseptic technique master, optimal catheter insertion technique and exit site care, prophylactic antibiotics for invasive procedures and wet contamination, infection control innovations. So all of these will be discussed under core aspects of prevention. If you look at the comprehensive patient education, this is basically the cornerstone in prevention of PD peritonitis, and this is an ongoing process. Education isn't just a one-time event, it requires continuous reinforcement. It equips the patients with the knowledge and the skills required for self-care and adherence. Studies has shown that it can significantly reduce the risk of PD peritonitis by 70%. So the initial training program should be an intensive hands-on comprehensive training program over 1 to 2 weeks period, and it should include sterile technique, exchange procedures and exit site care. It should be taught exclusively by specialized PD trained nurses. Patients must prove proficiency before discharge, ensuring readiness for home care. Reinforcement and retraining. Annual reevaluation is important. Targeted education for identified deficiencies to correct the bad habits. This is called as remedial training, which is also important. Home visits or on-site assessment is important to look at the home environment and practical application of the techniques. We have to address burnout of not just the patient but the caregivers as well. Sometimes this can lead to complacency, and that would directly lead to breach in the technique and increase in rates of PD peritonitis. Mastering aseptic technique is non-negotiable for preventing bacterial contamination during exchanges. Critical 7-step process of hand washing should be practiced to eliminate germs. Wearing mask is important to reduce airborne contamination. Surface disinfection with 70% alcohol solution is again important. Strict touch no touch policy, that is avoiding direct contact with critical connection points, is also important to prevent infection. So when is PD retraining indicated? Following any sentinel event, PD retraining should be performed. So what are these sentinel events? Prolonged hospitalization, peritonitis or catheter infection, change in dexterity, vision or mental acuity, change in supplier or a different type of connection, change in caregiver for PD exchange, and any interruption in PD. For example, if the patient has taken a break onto hemodialysis and is now coming back to peritoneal dialysis. This was a study called as Peritonitis Prevention Study. This was conducted by Sweden. It was an open-labeled randomized control trial. 57 centers across Europe and UK participated in this study. 600 patients were recruited. So the objective was to investigate whether a proactive approach involving regular knowledge testing and retraining of new PD patients could improve peritonitis outcomes. The study found no significant difference between retraining and control group in peritonitis rates. So basically it was just inferred as waste of resources that was involved in retraining so many patients across so many centers. So this result was reinforced by another study called as the Beijing retraining trial. They looked at 150 incident PD patients and randomized them into 3 groups. The first group received technique inspection, the second group received oral education, and the third group received usual care. The results showed that retraining did not significantly increase the time to first peritonitis episode. However, it did lead to a reduction in gram-negative peritonitis, though the results were not very significant. So this was another latest study. It was a pilot study, Teach PD, published in Peritoneal Dialysis International in March 2020. The research study tested a new educational package for peritoneal dialysis training called as Teach PD. So this Teach PD was based on the principles of Teach Back, task-based training and hands-on practice. The pilot study was designed to find out if this Teach PD curriculum was acceptable to the nurses and the patients. So 14 PD patients and 10 PD nurses were included in the study. And the results showed very good acceptability and usability of Teach PD, and none of them also developed PD peritonitis following this training program. Teach PD is now being tested in a large clinical trial. Coming to home hygiene practices for PD peritonitis, meticulous home environment is very important. There should be a dedicated exchange area. Patients should avoid dusty or high traffic zones during exchanges to minimize airborne particles. Crucially, pets should be kept away from PD supplies and the exchange space. Very important is proper and consistent waste disposal of all the materials used. Infection prevention at the time of PD access placement is also important to prevent catheter-related gram-positive peritonitis. This is substantially reduced by administration of perioperative systemic antibiotics, and the antibiotic choice is usually first-generation cephalosporin or vancomycin. Now let's see if PD catheter type has any bearing with reducing the risk of PD peritonitis. So this was a systematic review and meta-analysis published in the Journal of Nephrology, looking at the type of PD catheter and the outcome, that is PD peritonitis. So the catheters that were looked were single cuff versus double cuff, swan neck versus straight, coiled versus straight, weighted versus non-weighted. So the results showed that weighted or self-locating peritoneal dialysis catheters reduced tunnel infection, migration, drainage failure, cuff extrusion, and also removal. However, there was no significant difference with the outcome with respect to single cuff, double cuff, swan neck, straight, or coiled catheters. So clearly, if you're looking for a catheter, it should be weighted self-locating peritoneal dialysis catheters. Otherwise, there's no significant difference between other catheter types. Now, does embedded catheter have any benefit in preventing the risk of infection? So this was a single center retrospective study conducted in Canada. They compared 93 embedded catheters versus 76 standard or unburied catheters, and they looked at the exit site appearance at 2, 6, and 12 months post dialysis initiation. The results showed that buried catheter exit sites were not inferior, but clinicians should be aware of slightly increased infection risk during the initial months post externalization. So clearly, embedded catheters also did not reduce the risk of PD peritonitis. Now coming to catheter insertion techniques, this was the study published in KI reports in the year 2023. The study was conducted in UK. This was called as UK catheter study, a prospective nationwide study looking at medical insertions versus surgical insertions. They included 700 plus first catheter insertion, that is incident PD patients, and looked at catheter insertion events. So the catheter insertion events were basically peritonitis, exit site infection, hospitalization, catheter removal. So if you see here, medical insertions were associated with lesser catheter insertion events. Mainly peritonitis, exit site infection, hospitalization rates were reduced with medical insertion, but catheter removal rates were higher in medical insertion compared to surgical insertions. So the conclusion was that offering both medical and surgical pathways is associated with lower catheter event rates and keeps people on PD for longer period of time. So what does ISPD guidelines have to say about the choice of PD catheter type and placement technique? Clearly, there is no solid evidence or data, so the placement technique and the PD catheter type should be left to shared decision making between the individual clinician, the patient, and the local resources that are available. Now coming to the location of exit site, this should be carefully chosen prior to catheter insertion with the patient in multiple positions including seated position. The patient should be able to see and clean the exit site to avoid trauma. In cases such as obesity and ileostomy bags, distant PD catheter exit site locations can also be used, such as upper abdomen or the peristernal location. So in such cases, extended catheters are used, but these extended catheters increase the rates of catheter loss. Sutures should be avoided at PD catheter exit site. Again, this increases the risk of infection. Let's look at invasive GI and gynecological procedures in patients undergoing peritoneal dialysis. So here, this clearly shows that invasive gynecological procedures are associated with increase in peritonitis rate of close to 27% to 40% compared to colonoscopy and gastroscopy. This is because the proximity of the pelvis to the peritoneal cavity, and commonly reported bacterial pathogens in gynecological procedures are streptococcus followed by E. coli and even candida. So here is literature review of peritonitis following gynecological procedures in PD patients. So if you see, here is a list of gynecological procedures: hysteroscopy, endometrial ablation, pap smear, and so on. None of these patients received prophylaxis. They all ended up with PD peritonitis requiring antibiotics and antifungal as treatment. Some of them even had to undergo catheter removal. So there is no standardized recommendation of antibiotic of choice prior to invasive gynecological procedures. However, the antibiotic should cover gram-positive and gram-negative bacterial isolates from the upper tract of the female reproductive system. So studies have tried intravenous cefazolin or ceftriaxone before the procedure, or oral cefadroxole 500 milligrams once daily for 3 days. So following colonoscopy, more than 50% of the reported peritonitis is caused by E. coli. So findings from a multi-center study has showed overall peritonitis rate of 3.8% following colonoscopy in patients with PD peritonitis. Polypectomy and endoscopic mucosal resections were the risk factors. Peritonitis was found to be absent in patients who received antibiotic prophylaxis prior to colonoscopy. This was another retrospective observational study conducted in Hong Kong looking at 408 endoscopic episodes, and they found that antibiotic use was associated with the reduced risk of infection, while use of H2 blockers, elderly age group, and increase in the number of endoscopic biopsy were directly associated with increase in the risk of infection. Other risk factors noted were gastrointestinal problems like constipation, enteritis, and GI bleed. So what does the guidelines say about invasive GI and gynecological procedures? Prophylactic antibiotics should be given prior to lower GI endoscopic procedures, gynecological instrumentation, and other invasive procedures that may increase the risk of bacterial entry into the peritoneal cavity. So commonly the procedures requiring prophylaxis are colonoscopy with polypectomy, endoscopic mucosal resection, sigmoidoscopy with biopsy, gynac procedures. Dental procedures are more controversial, and the guidelines also states that PD effluent should be drained to keep the patient's abdomen empty before any of these procedures. This is in order to enhance the host defense mechanism, as PD fluid will reduce the action or the activity of macrophages and lymphocytes. So the antibiotic of choice is, if you're considering IV, it is cephalosporins or amoxicillin, clavulinate, ampicillin, sulbactam, ampicillin plus aminoglycoside. If it is oral, then this is suggested based on a case series of 49 PD patients. They received oral ampicillin, ciproflox, with or without metronidazole 1 to 2 hours before colonoscopy, and they did not experience any post-procedure episodes of peritonitis. Now coming to wet versus dry contamination. Dry contamination is outside a closed PD system, that is disconnection distal to a closed cap. Wet contamination is contamination of the open system. The contaminated dialysis fluid is infused into the body. So the examples include leaks from dialysate plaques, breaks or leaks in the tubing proximal to the tubing clamp, catheter set is left open for a long period of time, or any breach in aseptic technique. So if you see this study, this was a single center study conducted in Hong Kong looking at 548 episodes of touch contamination, out of which 300 were wet contamination, and the peritonitis rate was 5.6%. So if you see here, all the peritonitis episodes are following wet contamination and it is 0 following dry contamination. So prophylactic antibiotics is usually recommended following wet contamination and not dry contamination. And if you see here, the incidence of peritonitis in patients receiving or not receiving prophylactic antibiotics after wet contamination, those patients who received antibiotic prophylaxis following wet contamination had reduced peritonitis rates compared to those who did not. And in this study, the prophylactic antibiotic that was administered was a single dose of intraperitoneal cefazolin to cover gram-positive organisms. So what does the guidelines have to say? Prophylactic antibiotics is only recommended after wet contamination. If you are unclear whether the tubing clamp was open or closed, take it as wet contamination. Make sure to change the sterile transfer set and also send the PD effluent for cell count and culture. Monitor the patient closely for extended period of time to look for infection. Studies have shown that Pasteurella multocida peritonitis is common among domestic pet owners because this organism colonizes the upper respiratory tract in most cats and dogs. Other organisms are Capnocytophaga and Neisseria species. So this was PDOP study looking at domestic pet ownership and peritonitis. 55,000 patient months were studied. This was an international study with a median follow-up of 14 months, and they found that the overall peritonitis rates were higher among those owning both cats and dogs compared to those who did not own any pets. Also, the risk of infection was more among those who are on APD compared to CAPD. However, owning pets is not a contraindication to peritoneal dialysis, but patients should be educated about the importance of adhering to strict hand hygiene after handling the pets. Ideally, domestic pets should not be allowed in the room where PD exchanges are being performed and where the PD machine, solutions, and equipment are stored. Coming to exit site care, this exit site should be cleansed at least twice weekly and after shower using either antibacterial soap, povidone iodine, chlorhexidine, or sodium hypochlorite. No cleansing agent is found to be superior. Daily topical application of antibiotic cream, either mupirocin or gentamicin, is recommended at the catheter exit site, and it is meta-analysis has shown that it reduces the risk of Staph aureus exit site infection by 62%. However, surveillance for antimicrobial resistance is important. Proper PD catheter immobilization and avoidance of mechanical stress on exit site is important, and prompt treatment of exit site or catheter tunnel infection is also important. Now coming to adjunctive measures to prevent PD peritonitis. In this, we will be discussing about fungal prophylaxis during antibiotic use, nasal mupirocin for Staph aureus carriers, some modifiable risk factors like hypokalemia and H2 blockers, remote monitoring, and home visit programs. So in patients receiving antibiotics, generally oral nystatin 500,000 units 4 times per day for the entire duration of antibiotic therapy plus 1 week following antibiotic discontinuation is recommended. If you feel that the patient is immunocompromised, then you can always escalate to fluconazole. However, you have to balance the risk of systemic adverse effects, drug interactions, and emergence of resistant strains with fluconazole. So this is based on a Cochrane review system, Cochrane database systematic review. So here you can see that in patients who receive fungal prophylaxis, the rate of fungal peritonitis was just 18 per 1000 among versus those who did not receive fungal prophylaxis. It was 64 per 1000 patients. So clearly, fungal prophylaxis reduced the rates of fungal peritonitis by 72%. Nasal mupirocin should be used in patients who are identified as carriers for Staphylococcus aureus through swabbing. It should be applied intranasally twice daily for 5 days every month. So this is how you apply the nasal mupirocin. You can see in the images using your thumb, and then you have to press the nerves. So this targeted approach has been shown to reduce Staph aureus exit site infection rates by 70% and Staph aureus peritonitis by 50%. Again, PDOP sub-study has shown that persistent hypokalemia for 4 months increases the risk of peritonitis rate by 80%. This could be related to paralytic ileus arising from hypokalemia. So this was another multi-center open-label stratified RCT conducted in Thailand, looking at potassium supplementation in hypokalemic patients receiving peritoneal dialysis. So here the patients were divided into 2 groups. The first group received protocol-based potassium treatment to maintain potassium between 4 to 5, and the other group received a supplement when potassium was less than 3.5 alone. So this was a reactive group. And they looked at time to first peritonitis. Protocol based potassium treatment had higher time to first peritonitis versus usual care. So clearly, protocol based oral potassium supplementation to maintain a serum potassium between 4 to 5 was safe and reduced the risk of peritonitis in hypokalemic PD patients. Now coming to H2 receptor antagonist, this was a meta-analysis of 6 non-randomized studies looking at 800 PD patients. The subgroup analysis showed that H2 receptor antagonist use was associated with increased odds of enteric peritonitis, while PPIs might not. Safe storage and handling of PD supplies is important. The PD solutions should be stored in cool, dry place away from direct sunlight. Always check the expiry dates on the solution and the kits. Properly dispose of used materials to prevent contamination. Disinfectant containing connectors such as innovative sterile connect systems like the Ultra bag are very useful. Sometimes the mini caps which we use are also impregnated with povidone iodine. It enhances sterility and it is proven to reduce the rates of peritonitis by 30%. Some innovations in catheter design such as the swan neck, a unique curved shape minimizes kinking and reduces mechanical trauma at the exit site. The double cuff design, biocompatible materials reduces inflammatory response. Antimicrobial coatings, this is a promising area of research. These coatings aim to directly inhibit the bacterial growth on the catheter surface, offering an additional layer of protection against infection. The dressing should be applied properly. It should be gentle application without much pressure, preventing irritation or dislodgement. The dressing should be changed daily or immediately if it becomes soiled or loose to maintain optimal sterility. The catheter should always be secured to the abdominal wall using appropriate tape or devices to minimize movement and trauma. Optimizing connection systems for safety. If you look at the evolution of connection systems, initially it was the spiking system which was associated with increased infection rates, and of late what we are using now is Y-set to modern twin bag system, which are proven to reduce the risk of infection. Of course, again, the closed systems have significantly reduced the risk of contamination during exchanges. Automated PD reduces the risk because of reduced connection frequency and enhanced safety devices. The latest systems are engineered to keeping patient safety in mind. So here is the Y-set and twin bag system. Y-set reduced the rates of peritonitis by 50%. Twin bag system minimizes further air exposure during exchanges, again greatly reducing contamination. Continuous flow is maintained, allowing draining and filling without disconnecting, again preventing exposure. So Y-set and twin bag system has now become the standard of care. So finally, the PDOP study has shown that increase in the use of automated peritoneal dialysis, use of antibiotics at catheter insertion, PD training duration of more than 6 days, use of exit site antibiotic ointment was significantly associated with reduced PD peritonitis rates. Some future strategies. A few studies have been showing of late that home visit programs and remote monitoring by reinforcing techniques and early problem detection is going to reduce the rates of PD peritonitis. Psychosocial factors, it is important to address burnout of the patient, caregiver burnout, depression, and health literacy, which are directly related to PD peritonitis. Use of anti-biofilm lock solutions, which we have been using anti-biofilm lock solutions in tunneled catheters and in temporary hemodialysis catheters. So this could be tried in PD peritonitis as well, especially in refractory PD peritonitis. So some novel methodologies in research are use of probiotic therapy, intraperitoneal immunomodulators which can enhance local immune response in peritoneal cavity, use of bacteriophage therapy to target and kill specific peritonitis causing pathogens, touchless connection systems, microbiome profiling and precision prophylaxis, vaccine development against Staph aureus, digital tools and AI monitoring for early detection of infection and improve patient adherence through monitoring. So these are some of the methods which are strategies for prevention of PD peritonitis which are in the experimental stage. So this is the summary of prevention of PD peritonitis. Thank you so much for watching. Here is my email ID. You can reach out to me here. Thank you so much.